you, Colin. So, yeah, I think as a team doctor, we have to kind of exercise too, and not just stand on the sideline watching the game over there. So, no, it's pretty exciting over there. I cover like the Lincoln Mustangs, which is a local high school here in San Francisco, and then first time in like 100 years. They actually make the state finals and playing a team in San Diego, from San Diego. They're actually playing here in San Francisco in a couple of hours. So, but my intention is all on you guys in the next 3 hours, and I'll be away for a bit, for 2 hours, and I'll be back here in the afternoon. Okay, so we're gonna talk a little bit about shoulder this morning. Okay, so I know that you guys have great talks yesterday about hips and lower extremities over there. These are some of my disclosures. I think you can find it on the online also. Okay. So shoulder pain, very common problem, right? I love the shoulder, over there. A lot of people come in with shoulder discomfort. I'll probably see some of you guys later on today that complain about shoulder issues also. Most complaints are pain overhead, right? Bringing your arm above, the shoulder level, reaching towards the back. You remember when you're driving, kind of reach towards the back seat, bring something up to the front that's uncomfortable. Shoulder tends to be more painful at night. During the day, it doesn't hurt as much, but when you stand up, all the swelling goes down to your hands and feet over there. When you lay down at night, it tends to go to where it's most inflamed, which is where the bursa is. So night pain is very, very common for shoulder problems, and also, very debilitating because you can't sleep, you can't have the energy to work, do things the next day. It could be related to weak rotator cuff tendon. It could be related to some spurs in the shoulder people talk about over there. These are some of the x-rays we could get in the office to look at some of the chromial, changes in there. So, anybody have heard of this, the term impingement syndrome? Most of this, right? So impingement syndromes is kind of like, I kind of hate to admit it, when patient comes see me and I don't know really what's going on, I say, you have impingement syndrome. So it kind of sounds like a really, really, complex problem, right? So impingement syndrome. So syndrome means that there's no fixed diagnosis, means that you don't know what's going on, okay? Impingement is usually a fancy word saying, well, something is just not working right. So the idea is that the humeral head kind of hit the undersurface of the acromion, cause some impingement. Sounds very, very, technical from the patient's standpoint. They kind of believe you over there. Could be caused by a lot of different things, right? Impingement could be caused by muscle imbalance. When your rotator cuff tendons are weak or rotator cuff tendons are torn, you actually could cause an impingement. You could also have poor mechanics. Most of us stand in front of computers right now, seeing patients, right, typing. Okay, your shoulder cuff rolls forward. When you bring your arm up, it hits the top part of the acromion over there. So bad posture could cause, impingement. You could actually have instability. So the shoulder may have slight, movement, the extreme movement that give you, irritation also. So in terms of treating this over here, most of this is try to work on strengthening the rotator cuff tendon, work on better posture. So I'm going to look at you guys today in terms of how you guys sit in, in the room. Really have your shoulders back, sitting up over there. That's going to help your shoulders over there. No more computers in the front. That's going to help. Controlling the inflammation. Anti-inflammatory is going to help. Ice is going to help. Steroids are plus minus. We used to do a lot more steroid injections in the past. We actually tend to shy away from that a little bit now because knowing some of the injection may have some side effects in terms of causing the tendon to be weaker. And ultimately, we really actually don't do well with non-operative treatment. We do surgery to take the bursa out. It's very, very uncommon that we do subacromial decompression nowadays. I would say that, probably, 100 patients come and see me with impingement syndrome, but not really have a rotator cuff tendon torn or some instability. I just do an isolated subacromial decompression to take the spur out. It's probably less than 5% of the time. So, if you see some people come in and say, hey, you know what, so-and-so discomfort over there, failed non-op treatment, it's going to go have surgery. It's very uncommon that we do subacromial decompression. What do we do in surgery? I'm going to show you a little bit about what we do. There's actually a shoulder arthroscopy over there. We're looking at the top part of the shoulder, just to orient everybody. That's the acromion. That's the rotator cuff tendon down below. So I'm using this little burning device to take that bursa out. Remember, the bursa is actually what's giving the people pain. And I'm using this really aggressive, angry-looking burr over here to take that bone spur away. So what I do, I basically shave the bone spur. I kind of have some exposed bone. This is the end of the collarbone over there. And so now you have space between the bone and the rotator cuff tendon itself. So now I already kind of see someone sitting in the back row and say, oh my God, are you kidding me? This is going to hurt, right? Yeah, of course it's going to hurt. So I go and just kind of cut the bone, expose some bone. That's where all the nerves are. So this is a painful operation, even though the surgery John, how long does it take the surgery? An hour and a half. I mean, 1 minute, 1.5 minutes over there just now. We did the surgery, so it's not a long surgery. These are like probably about half an hour outpatient surgery over there, but the recovery is long. Recovery like 3 to 4 months or so means that you can move the shoulder pretty quickly, but it's pretty uncomfortable to sleep at night. Remember when we're talking about the night pain? Night pain is related to bursitis, which is inflammation. I just cause tons of inflammation when I go and take the bone spur away, and so don't expect like a quick recovery. Even a small surgery like this over there takes 3 to 4 months recovery. So there's no quick fix. I think that's the message for people over there. Okay, all right, so we're gonna have some questions. Keep you guys awake over here. So I think John's gonna sprinkle these, ARS, questions today. 45-year-old fell while snowboarding, which is coming. We have a great year coming up, for 2018, 2019. Acute shoulder pain, difficulty raising the arm up above the shoulder, difficulty sleeping. What do you guys think the diagnosis is? A, dislocation. B, frozen shoulder. Rotator cuff tear. Neck strain, or such a whiny over here, right? So we do see some of those patients over there. So, all right, so push on your buttons over here, and this is very common. We see, especially ski season is it's coming up right now. The weekend warriors go in rotator cuff tendon tears. Now, so you may say, well, why not dislocation? You can get dislocation. Tends to happen in a younger age group. I think younger people tend to dislocate shoulder more often. Older patients do get dislocation also, but older patient tends to get fractures. So 45 is kind of mid-range over there. And remember, the history also, if you really break the shoulder, they're usually painful enough they need to go to an emergency room over there. They have really hard time, even like slight movement. Rotator cuff tendon tear, they were hurt. They're still able to walk off the slope most of the time, but they cannot lift the arm above the shoulder. We're going to show a little bit of some of the tests we could do in terms of making diagnosis for acute shoulder injuries, because sometimes it's kind of hard when people are hurting. How do you make the diagnosis? But rotator cuff tendon tear is actually the answer for this one. So rotator cuff tendon tears could happen with traumatic injury, which we talked about just now, and also could be atraumatic. So rotator cuff injury could be a degenerative process. It means that as we get older, the tendon actually tend to deteriorate. Rotator cuff tears are very common in people in the age 50, 60, and 70 years old over there. So a lot of patients come to see us with rotator cuff injury in that particular age group. How do they present? They usually present with impingement syndrome, which is pain, bringing arm above the shoulder, and also weakness. So that particular examination we can actually focus on looking at weakness on the shoulder, isolate which rotator cuff tendon is injured, and also the classic any shoulder problem is going to give you night pain over there. Treatment for rotator cuff injury depends on whether it's traumatic injury or atraumatic. So I think I want to kind of have a clear difference between the two. I'm a perfectly normal person. I went to cover a Lincoln football game this afternoon. I got hit on the sideline and fell, can't lift my arm up. Well, if I can't lift my arm up for about a week or two, I'll get an MRI to show that I have a rotator cuff tendon tear. That's an acute rotator cuff tendon tear. I have a perfectly normal shoulder. Acute rotator cuff tendon tear, clearly normal shoulder before, now is torn. The tendons actually look really good. Treatment, fixation, surgery. Okay, that's actually very clear indication for acute tear, acute rupture, fix them. Most of the time people are saying, well, my shoulder hurts me. It hurts me for about 6 months. I lift my kids, school bag, to kind of bring them to school. It hurts when I kind of lift them back, see it over there. It just bothers me at night, just hurting more and more and more. You get an MRI on them, so show a partial rotator cuff tendon tear or a small full thickness rotator cuff tendon tear. Those are usually atraumatic, cuff injury. Atraumatic cuff injury, most of the time you could do well with physical therapy. So I think that, we could do strengthening. What are they doing in physical therapy? Physical therapy is not going to cure the tear, right? It's not going to make the tear go away, not going to make the tear heal. But what it does is actually allow the remaining rotator cuff to be stronger. So that allows you to kind of control the shoulder well. We call what we call force coupling. Strengthen the front tendon called the subscapularis, tendon. Strengthen the back tendon called the infraspinatus tendon. Really hold on to the shoulder. We talk a little bit about injection. If they're really, really uncomfortable with doing injection, rare we do it anymore because injection has been shown to actually cause the tendon weaker, may tear more. So we used to do a lot of injection, and sometimes, when they actually feel better, they do more things, they will rupture more of the tendon. So we're really cautious about that. Most of the time, we're going to do these surgery arthroscopically. Now, if it's a smaller tendon tear, for big tendon tear, we may have to do it open surgery. This is a video in terms of an arthroscopic approach for a rotator cuff tendon injury. That's a humeral head. That's a biceps tendon. The white is the tendon. You can see that there's a gap between the tuberosity and where the edge of the tendon is. So I'm putting this really, really big device to go in and grab the tendon with these sutures over there to tie the rotator cuff tendon down over there, for the patient. So what we do in surgery, just put the tendon back in place. It doesn't make it heal. You just put it back in place to allow the body to heal. So people say that, well, the surgery's done, I can move my shoulder right away. No, this is about a 4 to 5 months process because, once I put the tendon back to the bone, the tendon needs to heal, the bone needs to heal to the tendon itself. It takes about 6 weeks in a sling, 3 months before strengthening, so about 4 to 5 months recovery. So again, long process over there, okay? All right, so another question over here. So I tripped down the stairs this morning. I'm going to walk down, the hallway and fell on the shoulder. What is wrong with me over here? You can see the kind of little, unhappy face over here. Rotator cuff tendon tear. Is it a glenohumeral joint dislocation? Is it an AC separation? AC is acromioclavicular joint. Okay, so acromion and the clavicle. Or you could just say that I have a really, really nice bony appearing shoulder, not a lot of muscles in there, okay? Or as my partner, Dr. Allen, said, I need to go work out more and get more muscles over there. So, A, B, C, D, and E. So I think that, what we focus on is the right shoulder over here, okay? The right side shoulder is abnormal, okay? All right, okay, good, okay, perfect. Okay, so I don't know who's actually put in D. I want you to kind of meet me at the end, at the end of the session, okay? We're gonna talk about it, okay? So I'm very comfortable with my looks over there, so we're going to talk a little bit about that. Is it a dislocation, an AC separation? These are the most common. When you look at the shoulder, very abnormal looking. Clearly something's wrong, right? So you don't need to kind of say, oh my God, let me figure out what's going on. Get an x-ray, figure out what's going on over there. So, when you actually follow the collarbone joint over here, this is the clavicle right there. You can see the shoulder sits a bit lower over there. This is actually acute AC separation. So it means that, the collarbone went up and the, humerus goes down. It could be a dislocation. So I would actually say that the other 51% of the audience of that, I'll give you partial credit, over there. So a little maybe B plus over there. So yeah. But it could be separate shoulder because this is just one view. The difference about a separate shoulder and and also dislocation is that when you look at the shoulder, when the collarbone go really, really high up and the arm goes down, that's usually means it's separated shoulder. For dislocation, most of the dislocation is anterior to the front, and you'll see a bulge in the front part of the shoulder. They present a little bit differently also. Little, kind of a pet peeve to tell you about, the difference between the two. Obviously, both will be painful, right? Dislocated shoulder, shoulder's out of joint. Separate shoulder, the whole shoulder sits down. How to differentiate between the two on examination? Obviously, you look at the shoulder, see where the deformity is. The other thing is very simple, is that can they actually do this on the side? So that, when you rotate your arm on the side, that's your glenohumeral joint moving. So when you have a dislocation, you cannot rotate your arm on the side. Well, you can, but they would kind of say a lot of bad things to you when they do that over there. But this, dislocation, you cannot external or internal rotate the arm. For bad separated shoulder like this gentleman over here with a kind of, a sad face over there, they could still internal or external rotate the arm because the deformity or the injury is on top of the shoulder joint. So the whole shoulder sits down, but it could still internal external rotate. So a little bit of, a learning point over here in terms of examination about, too. Who gets, AC joint separation over here? Well, football players get thrown down to get, hit, and they do it. Falling on the shoulder could do it. Here in San Francisco, lots of biking, lots of cyclists. We got great muni tracks in San Francisco laid around the entire city over there. They fit perfectly for your bike tires over there. Especially when you go along the muni track, you hit it, automatic guarantee 100% you're gonna fall. Okay, so you either break your wrist or you actually separate your shoulder. Or when it's raining, when it's really wet and slippery over there, you can get that also. It's a very, very, very common injury we see here in the San Francisco area. Obviously, with mountain biking, which is kind of like the home of mountain biking here, is actually in Northern California here. So these are X-rays you can see on this particular patient. This is actually a normal shoulder in terms of orientation between the clavicle and also the acromion. Obviously abnormal over here, okay? So it's a very, very, obvious prominence, it's actually for severe ones. Now, for the lower grade separated shoulder, the one that's actually that's shifted, most of them could be treated non-operatively. They would do well. The famous one's Jerry Rice. Jerry Rice had a separate shoulder, right before Super Bowl, got it injected, played, got some touchdowns, and win some Super Bowls, but it's Jerry Rice, okay? We're not Jerry Rice over here. So most of us over here have a badly separate shoulder over here. It was shifted significantly, you need surgery, but they're actually lower percentage over there. These are the ones you actually look at the X-ray over, look very abnormal. Call your favorite orthopedic surgeon, get them to take a look at X-ray or look at your patient over there. They'll guide you in terms of what the treatment's going to be. Okay, if we do surgery over there, we have to go in and actually, repair the ligaments. It does take about 3 months for the ligaments to heal. Again, you kind of get in a little scenario, 4 to 5 months recovery. So when you do a surgery on this patient over here, about 4 to 5 months recovery in terms of surgical treatment for these people. Okay. Now, so this is a dislocation. This is a gentleman over here fell down. I think his hand's kind of covering a little bit over it. See the relationship? That's the collarbone, and the humerus is actually in front of the shoulder over here. This is the same patient over here. You see the shoulder again sits a bit lower, similar to the last picture, but doesn't have this collarbone way up in the air look over there. The humeral head is actually sitting in front part of the shoulder over there. Again, examination, no internal external rotation of the shoulder. So keep the arm to the side, rotate. They cannot do that over there. That's actually a separate shoulder for them. And 90% of dislocations go to the front of the shoulder. Rarely you actually dislocate the back. You can, but not so common over there. And most dislocations, especially older patients, you can manage it without, surgery. You can actually immobilize usually for a short period of time, mostly for discomfort, about a week or two. And if you do well over there, and after that, you can start physical therapy. The exception to treating this operatively versus non-operative is actually when you deal with recurrent dislocators. So it means that people have multiple dislocations. Once you dislocate more than once, you're very high risk to continue to dislocate. Also, when you actually knock off some bone when you dislocate the shoulder, those are indications to do urgent surgery. There's also a change in the philosophy in terms of how we treat it right now, especially for younger patients, because we do know that young patient over there, when they would dislocate, very commonly dislocate again. So those we may actually need surgery also. So we'll ask a question over here. We'll talk a little bit more about treatment. So 35-year-old, this must be Dr. Zhang, right? 35-year-old. So shoulder problem over here had come up 50 times over the past year. I don't know how you could come out 50 times and don't get treatment after the 45th time over there. Have to wait 50. But what's the most appropriate treatment over there? Is it physical therapy? Is it injection? Refer to your favorite orthopedic surgeon, Ben Ma. Okay, and refer to your most hated orthopedic surgeon. Who should I name? Brian Feely. Okay, so yeah. Or should we wear a sling over here? So what do you guys think? Yeah. All right, so I think, John, next time you should put my picture up here, okay? Favorite orthopedic surgeon over here. So, yeah, I think, for someone actually dislocated multiple times, remember that the indication for surgery is multiple dislocation, recurrent dislocation over there, and also bony injuries over there. Very clear indication for that, okay? Now, this is some of the data that's been coming out over the past 5 to 10 years, and where our group is actually part of it, part of the Moon study group that we do a lot of outcomes and research on shoulder. Found out that, the younger you are when you dislocate your shoulder, the very likelihood you get dislocated a second time. So this is the data out there. If you're 21 years or younger, which none of you guys are in the room right now, if you dislocate your shoulder, 90% of the time you get dislocated a second time. This number changes. As we get older, if you dislocate the shoulder the first time, your rate of redislocation drops down. So if I dislocate my shoulder today, about 10% chance I'm going to dislocate my shoulder the second time. On the other hand, if you dislocate a second time, doesn't matter what age you are, the number out there show that you're 90 to 95% of the time, you become what we call recurrent dislocator. So what's the message? Young patient, when they dislocate, not a good idea. So they actually become a recurrent dislocator. You probably need to have treatment. Older patient, when they dislocate, well, don't do it again, okay? So, learn from that mistake over there. You are not a skier, don't ski, okay? Because if you dislocate a second time, then you may have to do surgery over there for them. So I think that it really depends on the age group right now. I think that we're more aggressive on younger patients when they have dislocation in for the first time. But most of the indications recurrent dislocators or the high-risk recurrent dislocator, which are young patient, and all the bony losses over there. And physical therapy have not been, a non-operative treatment has not been shown to be successful to avoid recurrent dislocation. Quick question in the audience, yeah. So the question is, are the years between over there? The data show that if you actually don't have a second dislocation in 5 years, you're kind of back to the norm over there. But that's the numbers we quote people. These are large database that we look at over there, and they come up with these recommendations. So what do you do when you have a dislocated shoulder, right? So this is actually an arthroscopic surgery of a patient. I'm dislocating the shoulder in the operating room. That's the glenoid on your left-hand side and the humerus on the right-hand side. And the labrum is actually torn off the bone. I use the device to pass these sutures in there. They're green, they're blue. Sometimes they could be orange color also put in there. So basically, I use that suture to put that ligament back in place for you. So again, what we do in surgery physically is putting that ligament back in place to avoid the shoulder from dislocating. Again, it needs time to heal. The surgery itself literally takes about an hour or so. It's an outpatient surgery, arthroscopic surgery. Again, recovery takes 3 to 4 months because the tendon takes the ligament takes 3 to 4 months to heal back to the bone, and you work on strengthening also. Most of the time when I deal with an athlete, when they dislocate their shoulder, I don't let them go back to contact sport for probably about 6 to 9 months. So it depends on what activity they do, but 6 to 9 months. So something to kind of get them in terms of understanding what the recovery is like. Now, rarely you dislocate your shoulder in the back over there, but every now and then you have. This is obviously a gentleman over here who was speed skating. He came in with his arm in front, and also pushed his shoulder to the back. So who gets dislocation to the back of the shoulder or posterior dislocation? Obviously, direct trauma. Like this gentleman, you can see his shoulder come against the wall. He throw his arm out, boom. It basically pushes his shoulder straight backwards over there. Direct trauma like this will give you a dislocation. Other people get posterior dislocation would be people with seizure disorder that you may see in your practice. These are people with general tonic-clonic seizure. They will fall down. They contract so hard with their posterior musculature, they literally pull their shoulder out. So if people actually had seizure, or actually when they post-ictal stage, when they wake up, they kind of say, hey, I didn't hit my head, but my shoulder hurts over there. Make sure you get an X-ray on these people because they can get posterior dislocation. The really, really, really rare one is actually it get electrocuted over there. You get a posterior dislocation also. But more common ones actually the seizure disorder and the trauma patients over there. Okay. So this may happen to me, or actually not me, actually to my wife, tomorrow over here. She's 50-year-old female. She wake up with increased pain. She wake up one morning, God, the shoulder just started hurting over there. Difficult overhead type motion, and it become more and more and more painful. Again, it's really, really painful, and it's not because she doesn't want to take the trash out at night over there. It's really, really painful for her. And this is how her examination over here. She stands up over here. So over the past couple of weeks, she cannot rotate the shoulder. What do you guys think is going on here? So this is a frozen shoulder. So great, response from the audience over here. So when people come in and say, hey, my shoulder start hurting and no trauma, clearly no trauma, just hurt more, and really, really, really painful. Frozen shoulder is very, very painful condition over there. Usually happen with people from 40 to 60-year-old range, which some of us are in the audience over here. For whatever reason, female tend to have it more often than male. It tends to happen with people with some endocrine changes. Means that it may be diabetes, poorly controlled, maybe thyroid problems that was actually not diagnosed, over there, or maybe people going through menopause. So I think that's the age range that people see, and they usually present with very, very painful shoulder over there. So what's the treatment for frozen shoulder? So 50-year-old diagnosed with frozen shoulder, history of hypothyroidism, not taking her meds, what should be your treatment? Is it A, physical therapy on these patients, B, do an injection, C, checking the thyroid hormones, or D, anti-inflammatory medication, or all of the above over here? A, B, C, D, and E, yeah. So again, classic, demographics, right? 50-year-old, thyroid problems over there, not taking meds. Great, so great job. So all the answers are correct over there. So treatment for frozen shoulder is not surgery. Less than 1%, you can write it down, less than 1% of people with frozen shoulder need surgery. Usually are the refractory ones that don't get better with non-operative treatment, we do surgery. Majority of the time, this is a self-limiting condition over there. Physical therapy is a mainstay in terms of treatment to kind of move the shoulder. We could also do injection to selectively put, anti-inflammatory into the joint to cut down inflammation. We also could do anti-inflammatory, which is systemic, anti-inflammatory treatment. Check the underlying endocrine problem. If they have thyroid abnormality, treat it. Because if you don't get it treated, the frozen shoulder takes a little bit longer to recover. Same thing with diabetes. If you have poorly controlled diabetics over there, check the A1C over there and tell them to take their meds and make sure they're comfortable with that. Quick question, yeah. Correct. Yeah. Treatment is what kind of injection is it? Glenohumeral injection. You have to put it inside the joint itself. So some of you, we guys are talking a little bit about injections later on today, a little bit technique how to do it. If you don't feel comfortable, the radiologist could do ultrasound guided or fluoroscopic guided injection also. But you want to put that injection into the joint because the problem is actually a glenohumeral condition. So self-limiting, very, very painful. This is more painful than rotator cuff tears. Rotator cuff tears hurts when you move the shoulder. Rotator cuff tendon tears hurts you, more at night. Frozen shoulder hurts you all the time. It's angry and painful. Now, if you're tough enough, you wait long enough, it goes away. So most frozen shoulder, if you actually go from start to end, even if you don't do anything, 2 years it goes away, but it's pretty, uncomfortable. Treatment, therapy, decrease the inflammation. Again, rarely. What do you do in surgery? Surgery basically, I go in to take the inflammation away, and also I actually take some of the scar tissue and basically manipulate the shoulder and try to get the range of motion back quickly. So literally, for frozen shoulder, when I treat them, is that you come to surgery on Thursday, I will move your shoulder and break all the scar, and get you to start moving right away. Go to physical therapy right away in terms of move the shoulder over there. The problem with surgery sometimes it doesn't work very well is if you have a poorly controlled diabetic or someone actually have endocrine problems is not treated, you operate on them, they will get a lot worse. So very, very cautious in terms of surgical treatment over there. Most of them, would treat them non-operatively. All right, they move a little bit, so slightly, different condition over here. Shoulder pain over here. This is a retired Giants, player right now. He's a pitcher. He started throwing the ball and started lost some velocity. A little bit difficult with his delivery, and usually they come in a little bit frustrated in terms of what they're able to do. So this is sometimes what we call a slap lesion or internal impingement. Again, remember that word impingement means it's kind of a word that we don't really know what's in there. So internal impingement means there's something inside the shoulders impinging, but it's not the acromial spur. So these are usually younger patients. But slap lesions actually more specific related to the superior labrum, anterior posterior lesion. So SLAP stands for superior labrum, anterior posterior lesion. Very specific area, which is the top part of the biceps tendon, where they anchor the bicep tendon to the glenoid itself. Usually it's actually a disease of the overhead athletes over there. And actually when they bring the arm to the set point, when they over-rotate to go to the point where they kind of generate the power, that's when they have pain. And also when they kind of follow through over there, when the biceps pull on the anchor, they have painful. So like an overhead athlete would say, hey, I cannot get to a point where I can feel comfortable throwing, or when I throw a ball, it's very, very uncomfortable over there. That's a SLAP lesion. How many of you guys have seen SLAP lesion label on your patient's MRI reports? Some of you guys. We're going to talk a little bit about interpreting MRI reports, I think, this afternoon over there. It's very common. If you actually look at your MRI reports next time very closely, especially for someone that's coming for rotator cuff disease in the 50s, 60s range, everybody have a slap lesion. And the radiologists love slap lesions over there. They'll always comment on it. So slap, remember, is a disease of the overhead athlete that usually for young patients over there. As we get older, Colin, so 45 and above over there, okay, all of us have slap lesions. If I image my shoulder, I have a slap on my right shoulder, I have a slap on my left shoulder, and I may be asymptomatic on that. Is it, degeneration of the labrum itself is fairly normal process. So if you actually get an MRI report on someone have a slap lesion on an older patient over there, no treatment needed. It's called age-appropriate changes. Okay, so that's okay. It's not old, it's called age appropriate over there for you. Okay, so if it's a young patient with slap lesion, most of the time we treat them with non-operative treatment, which is posterior capsule stretching. We work on that, kind of correcting the mechanics also, and physical therapy would be important for these people. We rarely do surgery in overhead athletes. The reason why is when we do surgery, what do? We're going to fix something. When you fix something, it needs to heal. Obviously, you have to take them out in terms of doing sports. The other thing, when you fix something, it gets a bit tight. When you get them tight, what happens to them? They don't have the power to generate, the throw anymore. They can't rotate the shoulder where they want to be to generate the power. They actually lose velocity when you operate on them. So something that we're concerned about. If you have to do surgery, this is what we do. So this is actually a right shoulder. That's a glenoid, the shoulder blade, humeral heads over here. That's a biceps tendon attaching to the top part of the shoulder. See how unstable that is? Imagine this gentleman over here. You can over-rotate over there. This bicep will pull on the anchor. And also when you throw the ball, will pull on that area over for you. So these are different devices that we can go in to fix that, slap lesion. We put some anchors in the bone with suture to come out. We use these really, really gnarly devices so in to go and pull these sutures through, again, to tie that, labrum back in place. So again, what we do in surgery, basically, putting that labrum back in place, but needs to heal. But think about what I'm doing. I'm putting it back in place. I'm also tightening it up ever so slightly, right? So you lose a little bit of your rotation. And sometimes for an elite athlete, that little bit of external rotation will kind of, dictate whether they're a starting pitcher or a bench player or something like me that just kind of pretend I actually play baseball with them, okay? All right, so I think we have two more over there. 18-year-old college-bound quarterback. Landed on the shoulder after a tackle, hopefully not this afternoon or maybe on the opposing team over there. Okay. So this is the x-ray that we got at the stadium this afternoon, okay. This is the, humeral head, acromion, that's a clavicle that is broken, okay. So I'll tell you this is actually broken over here. Treatment, okay, A, sling and oxycodone, okay. B, my picture, okay, right? Favorite orthopedic surgeon over here. C, physical therapy, okay? Or D, send to a chiropractor to move on the neck a little bit. Or E, anti-inflammatory medication. What do you think the treatment is? I'm sorry? Oh, there's no point in this one? I'm sorry. So the treatment's actually, again, my picture. John, you got to make sure, he purposely delete that slide over there. So for younger patients, especially active people over there, I think that the tide has really changed. I think that when I was trained about 5 years ago in residency, we treat clavicle fracture non-operatively. Just kidding, about 15, 20 years ago, we don't treat clavicle surgery operatively because they heal. The data out there show that 90% of them heal. Well, what 90% means that they could walk in the office, move their arm up, and they leave the office. There's no radiographic evaluation. There's no patient-reported outcome 20 years ago. So these are actually one of the early studies about 10 years ago done by the Canadian Trauma Society. 132 patients, randomized them to operative versus non-operative treatment. They found that particular patients, if they're 2 centimeters short with their clavicle, or they shifted more than 100% or 2 centimeter displacement over there, they tend not to heal in this treatment. And also there's a difference in terms of operative versus non-operative in terms of return back to sports. For operative intervention with surgery, they return back to activity about 16 weeks or so. Non-operative, 28 weeks. 20 weeks, we're talking about 52 weeks in a year. Almost half a year. So it's kind of long recovery with non-operative treatment. Someone actually 18-year-old quarterback, maybe playing college, probably not good to take half a year off over there. And patient seem to have a happy outcomes after surgery. So I think the tide has really changed, and I think that, I used to operate on less than 5% of my clavicle fracture. I think that, the tide has changed a bit. I probably don't operate for displaced clavicle maybe only about 10% of the time. Usually these are older patients, or maybe the displacement is not so severe. Most of the time when you actually feel hard enough to break the bone's usually shortened, usually bones is displaced over there. The surgeries are better right now, so this is actually a good operation. So these are actually some of the pictures of what we do in surgery, putting this plate and screws in there, and the data is actually better in terms of outcomes right now for these patients. Shoulder osteoarthritis, we actually talk a continuum where younger patient fractures, and now we talk about older patients. So older patient with progressive pain and loss of range of motion. You can get shoulder osteoarthritis. This is actually a fairly normal shoulder. See, the humeral head is nice and round, like a ball, and a socket over here. That's a glenoid. This is a patient that actually have arthritis, right? See the big spur at the bottom over there? I think that this hopefully projects well at the back over the big spur at the bottom, and no space in between over there. Okay. You also have people with inflammatory arthritis. They could still have pretty good range of motion, but their shoulder creaks, give you noises. You don't see a lot of big bone spur. You see one over here, but clearly the space is completely worn out. And there's also a lot of cysts in the bone also. These are classic for inflammatory arthritis. Or people have post-traumatic arthritis. I may have dislocated my shoulder 10 years ago. My shoulder started to get worse and worse and worse. They develop what we call avascular necrosis, meaning the blood supply gets affected and the blood dies off and the humeral head collapse. So this is actually very, very deformed shoulder. These are very, very stiff shoulder. They can't move the shoulder very well. You can see that it doesn't even matches with the shoulder blade. So the different etiology for arthritis. This is a patient with cuff tear arthritis. I think you guys could probably see more and more in your practice, right now, that people may have rotator cuff injuries in the past. We're pretty good about fixing them right now. They do pretty well, still active, but then the tendon may actually tear again and develop arthritis in the shoulder. So this is actually humeral head kind of rising up and hitting the top of the acromion. See the glenoid is kind of worn out mostly in the top part of the shoulder. So that's actually what we call rotator cuff tear arthritis over there. Those are all different types of arthritis. Different arthritis need different treatment. So obviously the treatment is to try to manage the symptoms. Most of the time would be anti-inflammatory medications, injections, or maybe activity modification. Injection will be into the glenohumeral joint because this is a joint problem, not in the bursa. Injecting the bursa for plain osteoarthritis won't help as much. You have to put it inside the joint itself. Shoulder replacement is not as common as hip and knee replacement. I think with the projected numbers out there, I think in 2020 they're probably going to be about 750,000 hip and knee replacements, and they're probably going to be about 100,000 shoulder replacements. So hip and knees are much more common than shoulder. Well, why? Because we walk on our hip and knees. We don't walk on our shoulder. So even when you're bad arthritis in shoulder, people could still tolerate quite well. But as we get, a more active patient, as we live longer also, we do have people that want to have surgery done. Shoulder replacement is very common, now it's more common nowadays. It's also the fastest growing arthroplasty. So over the past, 10 years, it's probably about a 200% increase in the number of replacements done because there are more different surgery we could do right now for these patients. Total shoulder replacement is replacing both sides of the, shoulder, the humeral head, which is the ball side, and also the shoulder blade side, which is the glenoid side for the patient. Shoulder replacement can do really well. So I think, in the 90s, most of the shoulder replacement are done for fractures. They are not so successful. Now, actually, we're more and more doing people with primary osteoarthritis or rotator cuff arthritis, and we now actually found that the results are quite well. These actually, have long follow-up, 12-year follow-up over there. 93% of the implants are still in there in 10 years, 87% in 15 years. This is implant survival. When you ask these patients how happy you are 10 years after shoulder replacement, 85% of them, they say that they're actually good to excellent at 10 years, at 80% at 15 years. So this actually results as good as hip replacement right now. So actually much better over the past few years. So people with rotator cuff tendon tear, you can see this patient, the humeral has really rising up and can hit on the top part of the shoulder called the acromion over there. You can do a regular shoulder replacement. Regular shoulder replacement when you replace a ball with a metal ball and a plastic piece on the shoulder blade side. You have to have good rotator cuff tendon for those to work. If you don't have rotator cuff tendon like these patients over there, you can't do regular shoulder replacement. So these people do what we call a reverse shoulder replacement. So this is kind of what we do right now. Put the metal ball on the shoulder blade side, put the a stem on the on the humerus side over there. So very different from a total shoulder replacement. This is a reverse shoulder replacement. Some of your patient may ask you about that. Hey, I saw Dr. Feely at UCSF. He said I'm gonna have a reverse ball shoulder. I mean, this is kind of reverse shoulder replacement. The ball is actually on the other side of the shoulder. It gives the shoulder a little bit more stability. It can work pretty well. The results actually are quite successful right now for this replacement. Actually help a lot of patients over there. So I think I'm going to end over here. This is when a patient actually fell, break the shoulder, had a fractured dislocation, clear deformity. What could you do in these patients? You could actually do a replacement, or you could actually fix the bone. This is not just the bone breaking. When the shoulder breaks, it's not just the joints injured. The rotator cuff tendon is injured also. That's a problem. Bones could heal, but rotator cuff tendon doesn't heal very well. So when you do a surgery or do a treatment, you have to make sure the bones are lined up, which is, operative and non-operative. You also have to make sure the rotator cuff tendon actually restore back to where it's supposed to be. And a lot of times we actually forget about the soft tissue and just fix the bone, and patients don't do as well. So you could treatment like this, you could actually fix the bone and fix the rotator cuff tendon, or replace the ball, or in this case, we will replace the joint and the functional rotator cuff tendon using reverse shoulder replacement over there. So in summary over here, I think we went through a lot of different, shoulder conditions, but I usually kind of separate patients into categories in terms of how they present and what age group they are. Young patients, when they come in with shoulder problems over there, they don't get rotator cuff tears. Young patients don't get rotator cuff tears. They may have some tendonitis over there, but more commonly when people come in, young patients, they complain of dislocation, labral tears. They may have acute injury like a clavicle fracture. Middle age over there, they may have some bursitis, they may have some inflammation or impingement syndrome. Could be traumatic or atraumatic, like rotator cuff tendon tears or fractures. Or don't forget frozen shoulder. Atraumatic ones come in really, really painful, could be frozen shoulder. Older patients, you think about rotator cuff injury, you think about arthritis. If they fall, you think about proximal humerus fracture. So usually I kind of break down patient in terms of age group and how to present. I can make the diagnosis over there. So I'm going to end over here, take a little break. I think we're going to answer some questions, and then we're going to set up for the next section for some physical examination. Thank you. Yeah.